Welcome to the 2021 Robert S. Gordon Jr. Lecture in Epidemiology. My name is David Murray. I'm the NIH Associate Director for Prevention and Director of the Office of Disease Prevention. I'm very pleased to have the opportunity to represent Dr. Francis Collins today and introduce our speaker. The Robert S. Gordon Jr. Lecture in Epidemiology is awarded each year to a scientist who has made major contributions to research or training in the field of epidemiology or the conduct of clinical trials. The speaker selection is coordinated by the Office of Disease Prevention, and this is the 26th year that our office has sponsored the Gordon Lecture. The list of prominent scientists who've previously been recognized and received the award can be found on our website. The Gordon Lecture was established in tribute to Robert S. Gordon Jr. for his dedication to the field of epidemiology and his distinguished service to NIH. Over the course of 30 years, he served in numerous senior leadership positions, including Special Assistant to the Director and Chief Advisor for Clinical Practice and Research. He was an early organizer of efforts to address the emerging problem of HIV/AIDS and became a key coordinator for AIDS research. During the last 10 years of his service here at NIH, he made important contributions to policy and management issues regarding epidemiology, clinical trials, and the health effects of environmental hazards. Today's speaker is Dr. Kristine Yaffe. She is Professor of Psychiatry, Neurology, and Epidemiology and holds the Roy and Marie Scola Endowed Chair at the University of California, San Francisco. Dr. Yaffe is an internationally recognized expert in the epidemiology of dementia and cognitive aging. She serves as principal investigator on perhaps a dozen NIH, Department of Defense, and Department of Veteran Affairs and Foundation grants, and is a leader in identifying modifiable risk factors for dementia. She has more than 500 peer-reviewed publications dedicated to improving population brain health, describing her transformative research, bridging neurology, psychiatry, and epidemiology, and her work has formed the cornerstone for dementia prevention trials worldwide. In recognition of her groundbreaking work, Dr. Yaffe has received multiple honors, including the Potamkin Prize for Alzheimer's Research in 2017 and election to the National Academy of Medicine in 2019. Her presentation today is titled Epidemiology of Cognitive Aging, Why Observational Studies Still Matter. Please join me in welcoming the 2021 Robert S. Gordon Jr. Lecture Award recipient, Dr. Kristine Yaffe.
Thank you, Dr. Murray. It's really a pleasure to be the Gordon awardee. And I want to thank the Office of Disease Prevention and the Gordon Selection Committee. I recall we spoke about this last year when you notified me of the award, and we said, okay, I'll come to Washington, I'll come to Bethesda, and we'll hang out and give a talk and have a nice lunch and whatever. And then, of course, COVID came. And so we said, okay, how about we postpone it to the next year? And I became the 2021 Gordon awardee instead of, or in addition to the 2020 awardee. And so everything seemed hunky-dory, but things did not go according to plan. And here we are in this strange remote world. And I get to look at myself giving this talk and not at friendly faces in the audience. I don't think it's a coincidence that this last year, plastic surgery has gone, sky high because we're all staring at each other, at our faces. Before I get started, I just wanted to thank my colleagues. I'm going to cover a lot of material, and I want to make sure that I recognize all the great contributions that many people have made to this work. And of course, to the NIH, without whom very little of this work could be done and very little health sciences work could be done. And finally, I want to thank participants, because a lot of the studies I'm going to show you were grounded in people volunteering to be in a study. And often they don't get anything out of it really, but they're helping science or they're trying to help other people. And I think that's an important reference point for us all these days. So why do we care about the epidemiology of cognitive aging? And I'm going to focus a lot on why observational studies still matter and are the cornerstone for our work. Just to set the stage, part of the issue and the real urgency here is that dementia is going to triple in the US in the next 25 years, 30 years. And this is true throughout the world, by the way. The US, it's triple. In some countries, it's quadruple. This has to do with the fact that we're all living to be older. So this is a disease of an age-related disease. And although in this country, some life expectancy for some groups is leveling off, but nonetheless, we're living to be much, much older. And there are demographic shifts. So we know, for example, that the baby boomers are marching along and aging in a cohort. So we're going to see much more dementia. I need to figure out how to move this forward. I'm having trouble. Here we go. Sorry. When we talk about cognitive aging, what are we talking about? We're talking about sort of two things. There's a trajectory that's normal aging, and what that means is people may have mild changes in their cognitive performance, very, very subtle, doesn't affect their day-to-day functioning, particularly tasks that involve speeded kind of functions. And then there's another trajectory that we think is really more on the neurodegenerative path. This is the one that's more accelerated. And there's a period, probably a decade, maybe even longer, of very mild symptoms or preclinical. And then there's the mild cognitive impairment stage, and then dementia, which usually we're talking about Alzheimer's or vascular dementia or some combination. These are, of course, the most common kind of dementia, but other neurodegenerative diseases as well. So why are observational studies of cognitive aging an essential endeavor? First of all, they bridge gaps between mechanistic studies, trials, and public health. And I'm going to talk about each of these somewhat in depth. Very importantly, they generate hypotheses related to mechanisms and identify key risk factors that maybe we could do something about. Often, these kind of associations are difficult to test in trials for a variety of reasons. Maybe it's not ethical. You can't assign half the people to pollution and the other half to not. Or it may be very difficult to test these things. Also, it helps us identify disease risk and the burden in understudied and vulnerable populations, which I'll talk a bit about. And finally, it gives us a chance to estimate the public health impact of dementia and what risk factor modification could actually produce. Of course, there are limitations to observational studies, and many of you are aware of this. The most important problem, of course, is the issue about causality. You can't say for sure that X is associated with Y, and you can say it's X is associated with Y, but you don't know if it's causally associated, because there could be a confounding, a third variable that's associated with the predictor and the outcome. It could be reverse causality, and this is particularly true for cognitive aging because maybe somebody who has early symptoms of dementia chooses to not go outside as much and do physical activity or socialize, and it looks like it's physical activity that's protective, but really it's a reverse causality. There are issues around generalizability, although this is true, of course, for trials as well, but we need to get better in terms of looking at diversity and vulnerable populations, and I'll talk a bit about that. There are biases, particularly having to do with recall. If you're asking somebody who might have mild cognitive problems to remember what they did or what exposures they had, there's some biases. And of course, there can be survival biases, who lives to be old enough to get dementia. And it's hard to have cohort studies across the lifespan, which I'll talk a little bit about why that might be important. However, there are methodological approaches to address a lot of these limitations, and I'll touch on these as well. So the first section of my talk is really going to talk about why observational studies are the cornerstone for hypothesis testing and building the case for risk factors, particularly things that we can do something about. So this is, I think, one of the best uses of observational studies because we can work very closely with basic science and translate these outcomes into studies. The three prime examples I'm going to discuss are cardiovascular risk factors, traumatic brain injury, and sleep. Now, I could have come up with probably another 3, maybe 4 other ones that I think have very good evidence, but I think these are really interesting, and particularly because they're so grounded in translational research. Also, they're very common. So you might find that having 6 fingers is a risk factor, but that's really not very common, and it probably wouldn't have much of a public health impact. So I'm going to focus on these and go through each of these, why I think they're really interesting and ready maybe for prime time in terms of prevention. Cardiovascular risk. So what do I mean by cardiovascular risk factors? What I mean is classically hypertension, dyslipidemia, diabetes, and we know that these are very important risk factors, both with vascular dementia, vascular pathology, but also with Alzheimer's, and I'll show you some evidence that would support this. Of course, if we could control these things, we would benefit multiple organ systems, the heart, kidneys, eyes, and brain, etc. So it's a good area to think about. And of course, cardiovascular risks are very common, and they're good treatment options. So what kind of evidence do we have? Some early work, and this is a study led by Lenore Launer, who's in the NIA intramural program. And the top panel, she did some really important early work showing that midlife blood pressure was associated with increased risk of cognitive decline and dementia. And this was in the Honolulu Heart Study. And then with some colleagues at Kaiser, we did some work showing that midlife cardiovascular risk factors such as hypertension, diabetes, and high cholesterol were associated with late life increased risk of dementia. We also think that late life cardiovascular risk factors are important. This is some work we did a while ago where we looked at the metabolic syndrome, a constellation of cardiovascular risk factors, and we found that those with metabolic syndrome were at an increased risk of cognitive decline, particularly if they had high inflammatory measures, which is really interesting that there's this interaction. So suggesting that late life as well as midlife cardiovascular risk factors are important to intervene. There's been some nice work showing genetic linkages between Alzheimer's genes that they're depicted on the bottom. Whoops, this is crazy. I'm having a hard time. There we go. The genetic risk factors, genetic alleles for Alzheimer's are on the bottom, and you can see that many of them actually are linked to classic cardiovascular pathways, such as lipid metabolism, body mass index, coronary artery disease. So suggesting that maybe these have a shared genetic risk, and so that may be why having cardiovascular risk factors might, of course, increase your risk of dementia and Alzheimer's. This is some work that Rebecca Gottesman did that I think is from the ERIC study, which I thought is also very important in terms of a causal connection. What she did was she found that midlife blood pressure was associated with greater amyloid burden as measured by PET scan. And this was particularly true if one had an ApoE allele, which we know is one of the biggest genetic risk factors for a risk factor, not a dominant inheritance for Alzheimer's disease. So again, another piece of the puzzle that suggests that these vascular risk factors are associated with actual Alzheimer's per se. And finally, this is a really important trial that was published a little over a year ago, looking at, it was called the SPRINT trial, and they did an ancillary study called SPRINT Mind, in which they found that if you had more aggressive treatment of systolic blood pressure, that this actually reduced risk of mild cognitive impairment and probable dementia. And this is the first trial that's actually shown a way to reduce risk of developing dementia and MCI. So extremely important work, and I think really has now nailed the causal relationship between cardiovascular disease, in this case blood pressure, and development of dementia. I think we're ready for a life course framework. And what do I mean by a life course framework? What I mean is that even though we study a disease such as dementia that's really a late life disease, things that have been happening over the last couple decades, maybe even one's whole life, really matter. And yet often we can't study that. We're studying somebody from when they were 70 and above, and we've sort of missed their whole life exposure. So we need to get better at trying to incorporate these things. And I think observational studies are really the key at letting us figure out, are there certain time points where intervening might be most effective, or is it more of a cumulative risk exposure? And how do you kind of quantitate that? So cardiovascular disease is a good example of this because we know many people have cardiovascular disease, hypertension, obesity when they're younger. And in fact, it's starting to occur more and more even in children. This is some work we did from the Cardia Study, a very important study that has been followed for about 35 years. And what we did was we looked at people from when they were in their early 20s to about when they were 50. And what we did was we cumulatively calculated their exposure, in this case to just a high normal blood pressure, systolic blood pressure. These were not people who had actually hypertension. These were people who had high normal. And we were able, using the AUC as a way to sort of accumulate their exposure. And what we found is that at midlife, at about age 50, they had worse cognitive function, as depicted by these three different lines, with greater exposure to this low normal or high normal systolic blood pressure, suggesting that we might really be thinking about intervening on cardiovascular risk, at least blood pressure, earlier in life, and not waiting till somebody is 70 or 80. And another study has done this where they've looked at early life exposures to cardiovascular disease and then linked them later in life. I keep skipping, sorry about that, I don't know why. Anyway, same sort of idea that having risk factors in one's 20s might even, having one, maybe even two, accelerates the risk of getting dementia much later in life. We've done some work, this is with my colleague Adina Zeki Al-Hazura, who's now at Columbia. And what we've done is we've done some pooling. This is work also supported by the NIA. We've taken 4 different studies that span the life course, Cardia all the way through Health ABC and CHS. And we've been able to use this to get a sense of the exposure across the life course. And we've done some sort of complicated methods to impute these, thanks to my colleague Eric Widdinghoff. And so we can really try and extrapolate what the life course exposures would be, in this case, showing systolic blood pressure. And it's as you'd expect, it goes up with age, and there's some interesting race and sex differences that I won't go into, but are I think, very important. And then what we've been able to do is say, well, when does it matter that these blood pressure was elevated? And it turns out that at every point in life, it really mattered. So in early adulthood, it really mattered. In midlife, maybe a little less so because we adjusted for each time period, but also in late life. And so this suggests that we need to be thinking about these things across the life course, and that we shouldn't just be waiting till late life to try and intervene. Deb Levine has done some nice work as well, pooling some of the same cohorts, but some other ones, and trying to understand whether some of this cardiovascular exposure could explain racial disparities. And indeed, what she found was that the blood pressure was very important in terms of predicting cognitive decline. There were some differences in terms of Black and white rates of cognitive decline, but that a lot of this was actually attenuated when she took into account blood pressure, in this case, systolic blood pressure. So it suggests that a lot of the health disparities might be elucidated by using this life course approach and this pooling method, and we can then better get a sense of who to target and when. So I'm now going to turn to the second of the 3 risk factors that I think has very good evidence, and again, I think is grounded in fascinating basic science. We've heard about TBI, traumatic brain injury, for a long time. In fact, the first case report was in JAMA in 1928, and it was called punch drunk or dementia pugilistica. However, not much happened in this space for maybe 70 years or so, because I think it was hard to study. It seemed like it was a rare kind of thing. But now we know that about 3 million people a year in the U.S. go to hospital or the ER or die from these TBIs. So this is a very common occurrence. And we know that there's a bimodal peak of TBI. So little kids have a lot of TBI because they're learning to walk and they fall. But also with later in life, there's another peak. And that is because probably motor vehicle accidents, falls, etc. We need better studies to really get at this association. And I think in the last 10 years, we've seen some of these, particularly things that are taking into account things like confounders, such as PTSD. Many people who have a TBI also have post-traumatic stress disorder, and you need to account for that. Looking at better control groups, which I'll talk about, and also looking at competing risk of death. This is some work we did a few years ago with my colleague, Deb Barnes, the panel on the left, where we looked at older veterans using the National Data Repository. And we found that if you look at older veterans with a TBI compared to those without a TBI, you have about a 60% increased risk of developing dementia. And this has been nicely supported by some work, meta-analysis, which is on the right, and by Dr. Lee, and they found almost exactly the same point estimate of about 60% increased risk of developing dementia with the pooling, or doing a meta-analysis of all these different studies. Raquel Gardner in my group did a really nice, a thoughtful study in which she said, well, you know, people who have TBIs might be kind of different than people who don't, because maybe they're more aggressive, they're engaged in sports more or driving faster, different personalities. So what she did in a clever study was she looked at all the ER visits, and she compared those with TBI to those who had other kinds of trauma, non-head or brain related trauma, but maybe broken bones or other kinds of trauma, all seen in the ER. And what she found was across all different ages, the TBI had an increased risk of developing dementia. And this was a different hazard ratio, but basically all about between that 50, 60 increased risk that we've found previously. And then more recently, Dr. Barnes and I replicated our finding with the VA data, except this time we really tried to look deeper at the severity of TBI and also looking at mild TBI, even without loss of consciousness. So, and this has a lot of relevance for blast injury and for sports concussions, because these are the kind of TBIs which often are more mild and don't lose consciousness, or may not even make it to medical care. And we found really, again, this sort of nice dose effect, if you will, but that even having a mild TBI without loss of consciousness increased a doubling of risk of dementia. So what's going on? What is explaining this connection between TBI and dementia? Is it CTE, this thing we keep reading about, this chronic traumatic encephalopathy that tends to be seen on pathology, often in young, relatively young participants from sport injuries, often in the setting of behavioral changes, and then at autopsy, sadly, often after suicide, their brains are really quite different, and they show a lot of changes that are a lot of atrophy, a lot of tau. And so we sort of think, could that be what's going on? Or maybe that's not really it. Maybe it's really Alzheimer's or vascular. What exactly is explaining this connection between TBI and greater risk of dementia many decades later? And so this is some work from Paul Crane on the left, where he looked at a number of different cohorts and found doesn't seem like it is Alzheimer's or any of the sort of more classic kind of neuropathologic changes that we think of with neurodegeneration. And Mike Weiner and did some work on the right, looking at biomarkers, in this case, PET amyloid. And he found that actually the TBI group didn't really have an increased risk of amyloid as measured by PET. So suggesting it doesn't really seem like it's Alzheimer's. We've done some work as well with biomarkers, and in our hands anyway, we've been finding the same thing. It doesn't seem like it's Alzheimer's. Beta amyloid was not increased, but we do find greater inflammation, greater neurofibrillary light chain changes, which is sort of a non-specific form of neurodegeneration, and more GFAP and tau, suggesting that these are markers of neurodegeneration, but not the sort of classic Alzheimer's path. So it seems that there is this link, but we really need to understand more what is driving this and what is the underlying pathology. Brenda Plasman, who's a colleague at Duke, has undertaken a really nice study to try and get at this causal argument of TBI and dementia, in which she's used a creative use of the twin pair kind of study design. And this is sort of interesting because you can, because of their twins, who are discordant for TBI and discordant for onset of dementia, you control for early genetics, you control for early life exposures. And what Brenda has found is that, yes, indeed, TBI is increased with risk of dementia, about a 60% increase, exactly the same kind of effect size we've been finding. But it wasn't Alzheimer's. It seems like it's non-Alzheimer's disease dementia. And I think we need to understand more, what is that? Is it vascular? Is it CTE that's now met with aging? We don't really know. But I think this evidence really suggests that TBI is a very important risk factor, and we need to get better at preventing it and understanding what the connection is with dementia. So I'm going to now turn to the last risk factor that I think is really important and probably ready for prime time, and that is sleep. We know that sleep changes with age. A lot of interesting changes in sleep parameters, less deep wave sleep, less REM. We know sleep disturbances are very common in patients with dementia, particularly advanced dementia, but we don't know whether sleep might be a risk factor for developing dementia. And of course, it's hard because prior studies have often just used subjective measures of sleep, and it's not always clear what's chicken and egg. I think this is one of those examples where the basic science has been so fascinating, and it's really helped us figure out where to go. This is some early work by Kang and then by Xi, where we're basically showing that if you take animal models, rodent models, and you disrupt their sleep, that they actually have much greater amyloid deposition over that period of time and then long term. And this is true for tau as well. And then there's some interesting work showing that in the asleep brain, that actually there's much greater glymphatic clearance of these proteins. So suggesting that something about sleep, which of course we spend about 1/3 of our whole life in sleep, that during sleep, when the brain is quiescent, it's a time to be able to clear some of these toxins, particularly we think amyloid and tau, although probably there are many others we don't even know. So it's a really interesting foundation to suggest that sleep might be very important and might be extremely important in terms of risk of dementia. So what do we know about this from observational studies? This is some work from a study of older women, the STOST, Study of Osteoporotic Fracture Study, and Susan Diem, along with a bunch of us, looked at this issue of sleep efficiency. So what she found is that if you have less sleep efficiency, you're tossing and turning all night, you're not sleeping while you're in bed, or it takes you longer to fall asleep, that these all increase your risk of developing dementia and MCI over about a 10-year period. We also think that circadian rhythms are extremely important. And you see on the panel on the right that this is showing fragmentation of circadian rhythms, and that this is associated with the biomarkers in CSF that we know are true in Alzheimer's, so tau and A beta. And on the left, this is some work we did showing that actually if the peak, the acrophase, is not the usual standard timing, but is either early or particularly is late, that this is increased risk of MCI and dementia as well. So there's something about the circadian shift, if it's not as robust or if the time period is off, that this seems to be associated with greater accumulation of these proteins and greater risk of dementia. What about sleep disordered breathing? This is another very common disorder. We think about 50%, 60% of older adults have this, often not diagnosed. And sleep disordered breathing increases risk of developing dementia. We think that a lot of this is due to the amount of oxygen G saturation or the time in hypopnea, apnea, when you're not breathing. And actually, the panel shows you that a really nice study over a couple years, that when you got better with that amount of time in hypopnea or apnea, that actually there was a favorable change in the CSF A beta profile, suggesting that maybe we should be treating, maybe we should be doing trials for CPAP or other ways to reduce the amount of oxygenation and improve that profile, and that might have a way to prevent dementia. Yu Lang has done some work recently where she actually is trying to push this issue of, is it really causal? And she did some nice work. This is from the UK Biobank, where she looked at Alzheimer's disease risk scores. So she took people who had high standard use of a genetic risk score for Alzheimer's, and she found that even those without dementia had shorter sleep. And then she used this as an instrumental variable, which is a nice way to sort of try and get at the causal path, and found, in fact, that those with incipient Alzheimer's had actually a decrease of their sleep duration by up to 2 hours. So this suggests that there really might be something here between sleep and sleep duration and a causal association with Alzheimer's disease. And it might be a really good way to screen people who might be at risk for Alzheimer's. So I'm going to sort of end this part of my talk where I hope I've convinced you that these three examples are really exciting and that they form the cornerstone of translational research, connecting mechanistic studies to observational studies, primarily in older adults. We tried to show some ways to address some of the methodologic issues that do plague observational studies around causality, confounding, trying to look at the life course more. And I think all of these are really important because they're common. These are common risk factors, and we could really do something about them. So I'm going to turn now to why observational studies might help shed light on risk in vulnerable populations that often don't make it into studies. As we know, research often lacks diversity. If you're doing a study at the ivory tower, you're going to get a different group of people maybe than if you were doing it more in community-based research or even in populations that are hard to enroll in studies at all. Yet we have to do better, because if we're not including a wide range of people in our studies or trials, we just won't know the answer, and our treatments may not work as well. So we need more rigorous evidence in diverse populations, and this of course includes race and ethnicity, but also more extreme ages, oldest old, for example, and in certain vulnerable populations, such as the homeless populations, developmental disabilities, chronic mental illness, and others who again, they just don't make it into these studies. If you don't include these people, you're not going to know often the true answer or be able to tailor interventions that are best for a variety of participants. This is some work from the Alzheimer's Association, Facts and Figures, and then some work from Elizabeth Meyer, who did some beautiful work in Kaiser. They both show the same thing, and that is one looking at the prevalence on the left and on the right, incidence. And we know that non-whites, in this case on the left, Black participants and Black older adults and Hispanics have much greater proportion and prevalence of dementia, Alzheimer's, and other dementias. And this is true for the incidence data as well in the Kaiser population. So we really know that there's some important race ethnicity differences, and that this is a group that's a higher likelihood of having dementia. This is some work from Lisa Barnes, where she looked at older adults who had clinical Alzheimer's. So they had a clinical diagnosis of Alzheimer's, and then they passed away. And when she looked at the neuropathology and what was going on in terms of their brains, what she found is there's some big differences between Blacks and whites. So whites tend to have a lot more pure Alzheimer's that you can see in blue. And Blacks tend to have a much more mixed pathology, particularly in the red. You can see they had all different kinds of pathology, infarcts, Lewy body, Alzheimer's. And this is true as well with biomarker studies. So this is a CSF biomarker study looking at MCI, mild cognitive impairment, in Black and whites. And you can see that the biomarker AUC curves just don't perform as well in Black participants compared to non-Hispanic whites. And this is probably because the pathology is so different. And if you're using just a pure Alzheimer's kind of biomarker, it's not going to work as well because there's going to be a lot more mixed pathology. And we did some work a few years ago where we looked in the oldest old and kind of found the same thing. Whereas if you look at sort of typical neuropathologic findings of dementia, they just don't match up as well if people are very old. In this case, the oldest old, which is traditionally called greater than 85 or 85 or greater. So it suggests that we really need to be better at including these different groups in our populations, because only then will we be able to identify better treatments. If you're just looking at a treatment for Alzheimer's that was discovered, more in 60-year-old white people, it may not apply as much to everybody else. And there are other groups that we need to really do better understanding. I mentioned some of these. I just showed them here. Now, these people are hard to recruit into studies. So what can we do? It's hard to enroll them. It's hard to get people to come back, maybe. So there are some alternatives. And I think this is sort of a fun thing to think about, where the field is going. I think there are some other ways that you can actually capture what dementia or use other kinds of data ascertainment to get at what could be going on. So this is one in which Deb Barnes has recently done some work using EHR, electronic health records or electronic medical records, to try and find people who have dementia, but they haven't been diagnosed. So what they did was they very cleverly, they said, okay, if you have dementia, you're probably less likely to get your medicines refilled, or you might have more comorbidities. You may show up to the ER more often, or you may not show up to your appointments. A kind of combination of little signals that somebody might be having cognitive problems. And then what they did was they came up with a prognostic model to actually figure out who could have this unrecognized dementia. And now they're doing a trial to see whether actually by identifying these people, you could improve their care working with primary care doctors. So I think this is an important way we could actually get a much better sense of the dementia that's not diagnosed by using something, in this case, like EMR. This is another approach where you can use machine learning to try and figure out who are the people who are most likely to have dementia. This is some work that Laurent Claray did when he was visiting a postdoc with me a few years ago. And what he did was a really, I think, beautiful work where he took the HRS family of studies, the Health and Retirement Survey family, which had a dementia, a good dementia ascertainment in one of the studies in HRS called the ADAMS study. And he used that as sort of the gold standard. And then what he did was he developed a machine learning approach using all kinds of measures, demographics, health conditions, functional decline, mobility, neuropsychiatric symptoms. But he didn't use anything with cognition, which is sort of interesting. And he was able to, in a very convincing way, come up with this machine learning approach to identify those with a very high likelihood of having dementia. And it was interesting because not using cognitive assessments would really help us out. It's hard to get people to do a cognitive battery. And so this was really exciting. And then what he did is he applied this machine learning approach to the whole range of HRS family studies. And there are about 27 of these around the world, high income, middle, and low income countries. And what he was able to do was actually come up with, I think, better estimates of the global burden of dementia by using this interesting machine learning approach. Interestingly, in high income countries, the numbers were pretty similar, which because we had probably pretty good evidence of in high income countries. But in the low and middle income countries, he found numbers that were much higher than previously reported, probably because they just hadn't been captured. So I think this is another way that we can use sophisticated machine learning to try and identify those who are likely to have dementia, who might need to be either screened more closely or followed or offered treatment. And finally, you might have seen this one of these studies in the press a few weeks ago. We're surrounded by mobile apps and wearables, and I think we're just going to be using this more and more for all kinds of health, but certainly to be able to identify those at risk for cognitive impairment. And so there's one where it was a linguistic analysis looking at how people's use of different language declined or became less over time. Another is you can actually use how much people operate, how much they go out of their house, how much movement they have. All of these are really interesting tools. And I think our colleagues in Silicon Valley and elsewhere are really very eager to use some of these to either try and identify people at risk or to even do sort of more close monitoring. And again, I think we need to partner with them to better identify people and then figure out how to better care for them, because this is somebody who you might not even know about for a long time. Okay, so I'd now like to turn to the last part, which is how can observational studies help us estimate the public health impact, both in terms of dementia, but also in terms of what the risk factor modification might do. So we know now that there are some of these really important modifiable risk factors. We think that they have pretty good causal evidence, but how does this then translate to population-based strategies? What does this mean in the real world? And what could be the downstream effect on disease burden? This is some work that Deb Barnes and I did a few years ago, where we said, let's just have fun with this and let's think about these different risk factors. On the left, you can see we looked at about 7 risk factors that we thought had pretty good evidence. A lot of them are the cardiovascular risk factors that I mentioned. And we said, okay, how common are these? How common are they in the population? What's the relative risk associated with them? And from those things, we could calculate the population attributable risk, or PAR. And what we found was that even after we took into account that these things often are linked and are not independent, we thought that about 30% of the PAR was explained by these different risk factors. And of course, these are potentially modifiable. And others now have replicated this finding, most notably Norton in Lancet Neurology, and then in the Lancet Commission report, which I'll talk a little bit more about. So now there's pretty good evidence from many different studies and different parts of the world that we think 30 to 40% of the variance of Alzheimer's and other dementia could be explained by these modifiable risk factors. Now, that doesn't mean a one-to-one relationship, of course. This is looking in populations at the variance. And what we think is that if you could get people to decrease these risk factors on the right panel, if you get them to decrease by 10% in blue or 25% in red, you would have a really big downstream effect on dementia incidence. And you could really, have big public health strategies to reduce this. So I think this holds a lot of promise. Now, it's hard to get people to change their behavior, and it's hard to reduce some of these risks, but nonetheless, I think this gives us a lot of hope that we could actually have a big effect on the downstream effect. And lo and behold, there's been some really interesting studies that have shown something that seems a little off message. Now, I told you in the beginning of my talk that we know dementia is going to triple in this country and quadruple in other countries. But what a number of different studies have done, probably there are about a dozen studies, have now replicated this very interesting finding. And that is within the same research cohort, within the same study, whether it's HRS or CFAS or the Rotterdam study or the Kungsholmen study or the Framingham study, all of these have found a very interesting thing, which is over the course of a decade or two, the incidence for dementia seems to be declining in that cohort. So that's not in terms of the overall numbers. We know the overall numbers are going up. But if you take a study and you do the same case ascertainment separated over a couple of decades, there seems to be a decline in the incidence of dementia, which is really interesting. And so what could this be? Walters did a meta-analysis where recently they actually tried to combine most of these studies, not all of them, but a lot of them, and found the same thing, that in over 2 decades, there's been a decline in incidence of Alzheimer's and other dementia by 13%. So this is really interesting. And I think it provides us a lot of hope that we can do something at a public health level that might actually reduce dementia and have a downstream effect that would be tremendous. What is going on? What do we think has happened? There are a lot of secular trends here, and it's hard to tease out what exactly could be happening. Don't forget that if somebody was born, 10 years prior to World War II and they grew up during World War II, there was a lot of poverty, poor diet, poor quality education, terrible stress, terrible loss. That's a very different kind of person who might have been born around World War II or in the 50s. And so it's hard to really tease out what exactly is going on here. But we do think that a lot of this could be driven by the fact that cardiovascular disease has gotten much better treated. The statins were introduced, and we have different cutoffs now for things like hypertension and diabetes. So we think that actually a lot of this is due to improved cardiovascular disease care. We know stroke incidence has gone down as well. But also it could have to do with improved education, better economic well-being, better diet, so many different things. It's hard to know for sure, but I think it's a really interesting thing, and we need to understand, if possible, what exactly is going on, because the implications are enormous. I'm a little concerned, though, that if we did another point in time, if we did a third or fourth point in time in another decade or two, I'm worried we may be heading in the wrong direction, because as you know, we have big epidemics now of sedentary lifestyle, obesity, our kids are often obese, high rates of diabetes. So it's concerning. And frankly, I think that the quality of education, particularly in this country, is going down. So it is concerning whether we're on the right track and whether we'll see this down the line. But it also provides hope. So where are we with this question about modifiable risk factors and prevention? It's really interesting, but in the course of 1 month, these two very esteemed reports came out, separated in 1 month, which I think was a coincidence. One of them was sponsored by commissioned by the NIA and sponsored by National Academy of Medicine, and I was privileged to be on this committee. And in this, the level of evidence had a very high bar. So the level of evidence had to be a randomized controlled trial. The sample size was quite large, over 500, and there was at least 6 months of follow-up. And the report basically said, we don't know anything for sure. This was before the Sprint Mind was published, but it looks pretty good for blood pressure management, physical activity, cognitive training, but we really need more work. A month later, the Lancet Commission came out and they said, oh, well, we really think there are these 9 risk factors, and education, exercise, social engagement, smoking, hypertension, hearing loss, depression, diabetes, and obesity. And we really think that this is pretty clear that we need to intervene on these, and we should be ambitious about prevention. So it's really confusing, and I think it's confusing even to us who study this, and it's certainly confusing to people who aren't researchers in the field. What are we supposed to do? What works? What doesn't work? Are we ready for this, or do we need more work? So I think it depends a little bit on what level of evidence you're willing to go with. There are, I think, a number of really good strategies. They're linked very closely, I think, with I hope to have shown you, with mechanisms based from basic science. But it's still controversial. And again, it depends if you're only requiring randomized controlled trials as your evidence, like Sprint Mind, or are you willing to go with observational studies with very good evidence? There are a number of trials that are just sort of underway, particularly looking at multi-domain, looking at several of these risk factors in aggregate. But I'm not sure we can rely only on large randomized controlled trials. They're very expensive. They take a long time. You can't really get at the life course. Often these trials are a year or two in terms of the intervention, and you limit the population. So I think we need to kind of come together and start doing some of these more informed trials, or really trying to roll out some of these strategies now because they're beneficial to overall health. We know, for example, cardiovascular control, sleep, avoiding TBI, being physically active. These are all very important strategies that are helpful for the whole body, not just for the brain. And yet the evidence is pretty good for brain too. So I think that we are probably at a place to start rolling these out in terms of more prevention and even public health educational strategies. However, we also need more well-designed observational studies because I think these are the cornerstone that can really inform us of new risks and really try and make the causal argument even stronger. So I hope that I've been able to show you why observational studies still matter and why observational studies have to remain the cornerstone of our work. There is a great way to link back and forth with basic science, to inform basic science, and basic science inform these studies. You can actually very efficiently and cost effectively develop hypotheses related to prevention and try and use methods that really strengthen the causal argument. It's never perfect, but I think there are some good methods. And of course, you can try and study the life course. When do we want to intervene? When is it most important that these risk factors are exposures? And of course, I think we can do better in terms of the underrepresented and vulnerable populations and bring them into our research and really understand the mechanisms and risk factors for these populations that will, of course, inform better treatments. So ultimately, I think we're at a place where we can start rolling some of these things out in terms of interventions, but we do need much more work to really, I think, improve brain health and inform our health prevention strategies and policies. So with that, I want to thank the NIH, and I've been privileged to work with a number of different institutes, but primarily with NIA, also with the Department of Defense and Veterans Affairs. And this is our group that is trying to push along some of this. But again, there are many other colleagues that are not in this picture that I've hoped to mention some of their work, and I'm indebted to their help over the years. Thank you. I think we have some time for questions.
Yes, we do. Thank you, Dr. Yaffe. That was a wonderful presentation. And we have a number of questions that have come in from the audience, and maybe a few that I would add to the set, and in no particular order. Has there been any research on risk mitigation after traumatic brain injury with loss of consciousness?
I'm not aware of that per se. I think there's some groups that are starting to look at that. In particular, there's the Limbic Consortium, which I love the name, and I'm happy to be part of it. It's a really wonderful DoD VA partnership to really get at mild TBI in particular, and look at downstream neurodegeneration and among other things. And that group is trying to do some risk mitigation, but it's still more a bit exploratory, I'd say.
Has there been any research looking at use of CPAPs to address sleep disordered breathing on risk of dementia?
Yes, there has. There was a very important trial called Apples, which actually was a randomized controlled trial of CPAP. And unfortunately, and cognition was a secondary outcome. Unfortunately, it did not show a benefit with treatment of CPAP on cognition, but it turned out there were some issues there that make it, I think, a little hard to interpret, in that, first of all, a lot of the participants were pretty young, so they probably didn't have much cognitive impairment or change. And also there was tremendous lack of adherence to the CPAP. So that's part of the problem with CPAP. It's very hard to use, and it's not, so we need better tools, I think, to treat sleep apnea. So that was one of the big ones. There was a smaller study actually for CPAP in people who had dementia, and that looked like it might have improved the cognitive outcomes a little bit.
Does TBI increase risk of dementia because of a biological effect from factors such as systemic inflammation, or increase of free radicals from CNS injury, or is it working through a loss of cognitive reserve or something else?
Wow, those are really interesting questions. I think we don't know exactly what's going on, and I tried to get people to think a little bit about what it could be. I think it's a combination of things. I think this is my hypothesis, but I think that there are different mechanisms if it's mild TBI versus if it's moderate to severe TBI. I think if somebody has had a pretty significant brain injury, there's a static cognitive impairment often that I think as somebody gets older, they then have more decline, maybe because of other more typical neurodegeneration pathologies. And I think that's one sort of path that I would say is probably the cognitive reserve path. But then I think there's something different with the mild TBI people. The mild TBI, they don't usually have any cognitive deficit afterwards. Often mild TBIs are repetitive. The actual mechanism of the head trauma is quite different. And those are the people who we think probably have this accumulation of tau and maybe a different pathway. But I think, and a lot of inflammation. So the inflammation point is a good one. I think we just don't know enough about that yet. And I think it's an active area of investigation.
Are the relationships that you described between dementia and hypertension, TBI, and sleep found in minority populations? And if so, are there disparities in the patterns?
Yep. I'm not sure we know a lot about that. We did some work recently with TBI and race and ethnic differences. And we found that actually, interestingly, it was the white participants who had much greater risk of dementia with TBI. We don't know exactly why that is, but we think it may have to do something with ApoE, because ApoE is a important genetic risk factor for dementia, of course. And there are some differences in terms of both the prevalence of E4, but also its effect on dementia by race differences, and it's more so in white. So we don't know exactly, but there hasn't been a lot of race disparities in terms of TBI and dementia that I'm aware of, other than our recent study. Cardiovascular, there's a lot. I think there's a lot of interest in cardiovascular. We know that there are huge disparities in cardiovascular disease, and I tried to show you some of those, including Deb Levine's pooling study, where she's showing that a lot of the difference in cognitive change might be explained by these differences in cardiovascular disease. And so I think that's a very well studied and important area. Sleep, I haven't seen so much. We have a study that's ongoing that looking at in Mexican American older adults and compared to whites to see whether there might be differences in terms of sleep.
A bit of a different question. Is dementia a quantitative as well as a qualitative diagnosis? If quantitative, is there an agreed upon disease severity score for dementia, and how does that impact longitudinal studies?
Yes, so I would say it's both a quantitative and a qualitative diagnosis, but they're pretty clear criteria in terms of the clinical diagnosis and certain severity scales. There's a number of severity scales. One of them is the Clinical Dementia Rating, CDR, that's used a lot in trials and in dementia populations. So yes, they're both.
Prevention trials, of particular interest to me, require modifiable risk factors with good evidence linking those risk factors to the outcomes of interest. But they also require outcomes that can be measured within a reasonable time period. You've spoken about modifiable risk factors. What about outcomes that could be measured in trials?
Yeah.
There's incidence of dementia clearly, but that's a challenge.
A long time. Yeah, that's hard because people who come into trials are are often pretty high functioning because they're willing to do all this stuff and come back and forth. And So yes, looking at incidence of dementia takes a long time, often, 7-10 years. And that's, I think the Sprint Mind dealt with that because they just didn't have a lot of cases of dementia. But when they looked at the mild cognitive impairment plus dementia, they did achieve enough power. So it does take long follow-up if you're going after dementia per se. But I think there's pretty good evidence now that some of these, using repeated cognitive measures, looking at the slope of the change in these measures, particularly say memory or executive function, are really very good ways to get at this, and they may require a year or two of follow-up. The other thing, of course, is now we have these great biomarkers. So I think we need to partner for some of these prevention trials with biomarker, and that you can see whether the biomarker is shifting at all, and then translate that to the outcome. So I think there's a lot of things that we can do now that we did not have really accessible 10 years ago.
A question going in a different direction. What about pollution? What do we know about it as a risk factor and differences in age and length of exposure? What do we need in order to tease out the impact of pollution for the future work in this area?
Yeah, so I think pollution is really important. It hasn't gotten a lot of studying. Recently, there have been a couple of findings linking pollution, whether it's particulate matter with cognitive outcomes. There's been some very important work with pesticides, for example, that a lot of that work was primarily with Parkinson's outcomes. We know there's a connection with pesticides and in some environmental toxins with Parkinson's. So I think it's an area people are getting very interested in and starting to look at it more closely. It's a little hard sometimes to follow. It's hard to get the exposure sometimes, and I think we need to get better at learning. There's been some nice work with geocoding, trying to look at certain areas. We actually just published something last week on Agent Orange and risk of dementia. So I do think it's an area that people are very interested in, and there are huge issues around disparities because people live in different places, and some places are much more much higher exposure to pollutions of all kinds.
Right. A related question, what do you think about the hypothesis that removing lead from gasoline in the 80s is in part driving the secular trend for dementia?
It's a good idea. I hadn't really thought about that one, but some of these policies are really interesting where you can apply, certain policies and then look before and after whether things have changed. There's been some beautiful work Maria Glymour has done with changes in education policies and tracking how that affected dementia down the line. Mm-hmm. But it's a good question, and I don't know enough about whether that would have maybe been part of the equation.
You've talked a bit about the challenges of doing prevention trials. It takes a while for some of the outcomes. It's hard to change behavior and so forth. What about adding dementia-related measures to trials that are focused on controlling blood pressure or addressing TBI or some of the other risk factors that you identified, and then pooling data across those studies in a meta-analytic approach to find out if the intervention had some beneficial effect on cognitive outcomes?
Yeah, that's music to my ears. I think we need to get better at working with our colleagues in cardiovascular disease, in oncology, infectious disease, and adding cognitive measures. There has been some work that has tried this. In fact, I'm in the middle of reviewing this for a manuscript that I'm late on, but what it was I was really struck by going back at some of this literature from 10, 15 years ago. A lot of the times the measures were quite insensitive. So when you're doing a big trial of heart disease, people may say, okay, we can add one thing, and they added the mini-mental or something that really wasn't very sensitive probably to detect change, which gets back at one of the other questions about what are the better outcomes. So I think we should be doing that more. And it's very cost efficient, you know, to tack something onto another trial. And I think we need to do it, you know, much more. But there are some good examples of that. And Sprint Mind's a good example. You know, it wasn't the main goal of Sprint.
Now, I haven't actually heard from my friends at NIAAA, but I would be remiss if I didn't ask, what about alcohol?
As a risk factor?
Yeah, or interacting with some of the other risk factors that you've talked
about. I'm not sure we know the answer. You know, there's this proverbial U-shaped curve with alcohol, where if you study older adults and you find the people who don't drink at all versus the people who, you know, drink one glass of wine or whatever, there's this difference, and you know that somehow one glass is protective, and you know, no drinking or too much drinking is harmful. A number of studies have replicated this, so I think that U-shaped curve is probably valid. I just am not sure how much is the alcohol versus some of the other things. I mean, it's not your typical person who actually is able to just have one glass of wine. And so there's socioeconomic status issues. I think there's a lot of other things that go into it. So I think I don't think we really know that much about alcohol. It's surprising to me.
Let's close with this question. What advice would you give an early stage investigator to go about in terms of developing a career in this area?
Go for it. No, it's hard for me to say. I think it's a fantastic area. I think really staying grounded in some of the basic science is really fun. I think being able to look at some of these things, particularly things that are common that you can do something about, has a big public health, grounding, which I think is really important in our work. So I think it's a great area. I also think, for better or for worse, the fact that we haven't had good the last time we had a treatment for Alzheimer's was 20 years ago, and that was not a particularly efficacious treatment. So we really have not, we've been stymied without having good treatments for Alzheimer's and other dementias. And so, I think this area of being able to understand risk factors and do something about them is taking on more and more importance.
Thank you, Dr. Yaffe, for a terrific presentation, and to the audience for lots of very good questions. I want to repeat the CME code for those of you who need to use it. It's 31295. And as I mentioned earlier, we will be posting a recording of today's presentation on our website, prevention.nih.gov, next week. I want to thank Dr. Yaffe for a terrific presentation, and thank everyone else for joining us today. Thank you very much.